We already have a question in our chat box. It's from Dr. Hemarino. Question is, how many minutes do we need to wait from supine to prone to see improvement in the O2 sat? Because we see a few patients who have worsening O2 sat when prone, then we revert back to supine.
Thank you for that question. It's a great question. I don't know that I have an absolute answer. I think it is important to know that this can happen, especially when you just ask somebody to prone. Part of that, I think, is going to be a little bit related to the exertion, of just asking somebody to flip over when they're already struggling a bit to breathe. I would think, on average, in terms of personal experience, what I've seen, maybe 5-10 minutes, we start to at least see it stabilize and then slowly improve. I think it's important to wait. Sometimes that's hard to do. I think, especially in the next talk, when we look at proning in ventilated patients, sometimes it's hard to know when you flip them back over, especially if they're quite unstable. But we can also see hemodynamic changes when we first ask somebody to prone. And it's important to know that this happens, that it may pass. And I think a little bit on how long we wait will be how severe these effects are.
Thank you. I think Dr. Hemarino has an additional question. He said some clinicians are very wary in doing prone positioning, especially in the presence of hypotension and the use of vasopressor. How do we define severe hemodynamic instability? Thank you. Excellent lecture.
Thank you. Again, this may be something that we see more when somebody is ventilated. I would say that even in patients who are or require a fairly high doses of vasopressors, we have been proning. I think, our teams have become very skilled at knowing that, we may have a transient need to increase our vasopressor support, but generally we are able to wean that back down. Again, I think it's because in that patient population, we see it more because they are, really sick. And anything, can result in a little bit of an increase in that need for support, at least transiently. I think, somebody who really plummets their blood pressure, those are the patients that we tend to turn back really fast and say, okay, we can't prone. But, even people on moderate levels, even, high levels, and for us, we have this arbitrary maximum in Toronto, maximum in quotation marks, that in terms of policies of what our nursing team is allowed to, increase their inotropic or their vasopressor doses to of 0.35 mics per kilo per minute of either Levophed or adrenaline or both. And, even when we are on that level, as long as we've got some stability in the pressors, we will still try to prone them. We are very aggressive in terms of proning this patient population because of the benefits that we've seen. And even in the awake or, patients who are on the ward, when we go up as part of the rapid response team, I think one of the biggest interventions that we do is to encourage the teams to encourage the patients, and we, work with the patients directly as well to understand why we need to ask them to prone, to deal with the discomfort that it causes, and to explain the benefits of proning in terms of that reduction in need of intubation. We weren't as strong at using the ROX index as we could have been. There's a lot of literature emerging now about ROX and thresholds and stuff like this. The literature is a little bit messy right now, but I think the overall idea is that you can use the ROX index and a failure of that ROX index to improve to indicate a need to keep a closer eye on someone. Some people are suggesting instead that 4.88 cutoff, that there's a higher cutoff closer to 6. Some people are saying that they find that it's more stable at around the 12-hour mark. What we did for our wards is we actually had portable monitors that we had repurposed. So they were part of our bariatric program. And what we did was we grabbed them and, like Robin Hood, brought them to the internal medicine wards and hooked our patients up to that, so that we were, able to keep a closer eye on their respiratory rate and oxygen saturation and, their high flow needs, using these devices as well. So while we didn't use the ROX on a formal basis, we had an ongoing sense of it. And I think that continuity of understanding what is happening with any given patient is important. But teaching them and actually giving them the sheets, as I said in that talk, really made a big difference in them being able to do it.
So it's really very important that education becomes part of, telling them about prone ventilation, or at least awake proning, because it isn't sufficient to just try and convince patients about, this is going to be better for you. You really have to extend and be patient about talking to them about the benefits, or at least later on, the discomfort is worth the outcome.
Yeah, and not many of us lie on our stomachs, even when we sleep at night. And so, but I think a lot of people started to notice, that they felt a bit better when they were prone. And I think, as soon as they start to see, now not everybody does, right? We heard yesterday about the happy hypoxia component, which we've all come to know so well, having treated patients. But, those who still maintain that sense of dyspnea, these patients, if that helped when they're prone, again, it acted as positive reinforcement. I think the biggest issues that we had encouraging people were the discomfort. So important to manage their pain. And also patients started to cough more. And a lot of people found that really uncomfortable. And, just again, that education explaining why they were coughing, that sort of movement of secretions and how that was actually a good thing, helped. But it did take a lot of support and, a lot of just holding their hands sometimes, just to tell them that, we weren't doing this to be, overly firm with them. We were doing this because there is evidence that it may help them.
Dr. Habana asks, are there any precautions on how patients are fed?
When they're prone? So we would actually have them turn back, eat. The really, really sick ones that we were very worried about in terms of their progression, we would ask them to go NPO for periods of time, and then we would try to get them to eat clear fluids if we were getting increasingly worried, and sort of manipulate their diet a little bit in case we did have to intubate them. And I think that, again, was one of the hardest things. A lot of patients, were so short of breath that they didn't really want to eat all that much, at least during those really critical phases of COVID, until they started to feel a little bit better. But we would ask them to eat, and then we would prone them immediately after eating, more or less, like, within half an hour or so. And they seem to tolerate that okay, by and large. I think the biggest issue that we had was I think the use of a Foley catheter, who you put a Foley in and who you allowed up to go to the washroom. That became a spot of discussion between us and internal medicine. Medicine would encourage them to use commodes or bathrooms that were in the room, and we'd be like, no, we don't, they're getting too hypoxic. We can't have them moving around that much. And, that was something as well that we had to really figure out, okay, do we have to put a Foley in or not? The ICU is very used to just putting Foleys into everybody. Probably we use them too much, frankly, but when you start to see those SATs plummet, and how everybody with COVID, well, not everybody, but a lot of people with COVID have very sudden desaturations. And, when we were first getting to learn about this illness, we never knew if those saturations were going to recover, or if that was going to be it. And that was going to be the moment that we would have to intervene and intubate. And, as our ICUs became overwhelmed, we were managing these patients on high flow, being prone or self-proning on the ward. And so we weren't watching them. We were coming around often, but, we were relying on other people to watch them. And again, those moments of desaturation are frightening. And, I think we've become a bit more comfortable with that, but it's never an easy feeling when you see somebody's oxygen saturations go down into the 70s and you don't know if they're going to come back up again. As you watch that person more and more, you get a feel for it. But when you're managing an ICU effectively with your colleagues who don't usually look after people who are so sick on a ward setting, it's a very different feeling, as we all know.
Yes, I agree. It becomes also very difficult to try and watch the rapid desaturation when it takes you longer to actually recruit them when you put them back on prone.
Yeah.
Stephanie Macapaz mentioned or said, I had observed that patients on high flow oxygen can also be placed in prone positioning. Is it necessary to increase the FiO2 if there will be decreases in oxygen saturation?
No, in general, we only increased the FiO2 in response to a change in the patient. We did not preemptively change the oxygen concentration. In fact, we were often able to wean it when they were in the prone position compared to when they turned back supine. And that was one of the nice things to see. I must say that, high flow oxygen for us became something that we gave a name to because we were using both high flow oxygen and 100% mask on some of these patients. Now, these were the ones that we generally tried to bring down from the ward and have them closer to us in the ICU. But our high flow oxygen is called OptiFlow. So this became OptiVish because the 100% mask was known as a TAVIsh because it had the filter on it. So SIBS will be able to attest to our use of OptiVish, which was something that we'd never done again before, trying again to see if we could get somebody through without intubating them, especially as we were talking about with Dr. Brochal yesterday, the time of intubation of these patients, I think, is something that was one of the biggest challenges for ICUs. It's really hard to sit and watch somebody and not act. We are trained to act, and to be with somebody is a whole different aspect, especially, again, during these moments of desaturation. And again, when we initially had that fear of high flow and non-invasive ventilation use in these patients. So, we did a lot of really high flow oxygen, and perhaps in ways that, weren't quite the high flow studies that we see, but were even higher. Does that induce, I'm going to take some of these studies on, does this induce, a patient, lung injury or generated lung injury when we wait and or, when we prone? I think proning can reduce, patient-induced lung injury, in the sense that, you are recruiting lung and using, more of the bulk of the lung tissue that we have in our bodies. And therefore, hopefully, as we spoke about in this with the concept of shape matching and chest wall compliance and recruitment, holding more lung zones open, draining secretions. So this all should reduce the lung injury effects that we can generate. Now, this being said, we still, especially in the Delta wave, going back to that issue of barotrauma that we were talking about yesterday, even in people who we were proning, and we had some of them also on NIV, we were getting barotrauma in the Delta wave patients a lot, like much more than what we've seen in Omicron. And you know what, I can't help but think that there was some component of the way, the virus is interacting with us with the Delta mutation that is slightly different, because it was extraordinarily significant in terms of what we were seeing compared to all the other versions of this virus that we've lived through so far. And we hadn't changed our therapies that much. Even with Omicron, while we have interventions that we use, again, we were using these with Delta as well. So I don't know that it's just our treatments that have changed. I think there is something there with the virus that may emerge down the road when we have a chance to go through all of this. Does proning have the same effect on age? Yes. We prone elderly, we prone young, we prone everybody that we can get our hands on. And it seems to hold, the benefits seem to hold throughout the populations. It doesn't depend on demographics. It's more, again, those lung dynamics and how we're built as people.
Yes, because I think that was one of the concerns about, having the cervical spondylosis or the instability of the cervical spine when it comes to the age of the patient. But as long as there's no cervical instability and it's just spondylosis, I think that would be safe enough to do the proning. And of course, having to adjust with the positioning. I think you mentioned that the use of particular pillows can actually address concerns about that particular discomfort of the neck.
Yes, and also, even the other joints, like shoulder joints tend to be, and pelvis can also be very difficult, sometimes knees. But again, if we work with that person to find something that helps them be comfortable, then we can typically succeed. I mean, we haven't been able to do it in some patients, but to go to another one of the questions in the Q&A section, yes, if we've gone to lateral position changes, in that case, we've tried to do what we can to move that patient, and in that graphic, it shows you the variations that you can ask somebody to do if they can't prone completely. Ideally, we go for proning, but if not, then we'll try those Q2 hour position changes.
And you can have a bit of a in-between, a prone and a lateral position if that is more comfortable for the patient. Would that be possible, or is that also okay?
Yes, that is also okay.
Okay. I think we have a few more minutes. Let's see. Do you have experience in awake proning in non-COVID patients?
No, not personally. But I really think that, if we look out of all the negatives that we have lived through, both within healthcare and within our broader population, in terms of what we can do to help people who need us moving forward, I really think that awake pronane is something that we need to bring with us when we emerge from this, and look at it in patients who come with, acute respiratory infections, and, try this to see if it can also help them, not need us. Because as we all know, it's really better not to need the ICU. The smallest footprint that we can leave on a patient, the better it is for everybody, especially that person. And if this helps, then it would be fantastic. But I think we need more experience with this. It's certainly worth trying.
Yes, definitely, especially with the trying times. Thank you so much. Thank you for a very wonderful talk, Dr. Horiluck, and I actually enjoyed our Q&A.
Thank you.